Welcome to perioperative nursing care. In this lecture, we will cover preoperative and intraoperative care. Today, as a result of advances in surgical techniques and instrumentation, as well as in anesthesia, many surgical procedures that were once performed in an inpatient setting now take place in ambulatory or outpatient settings. Patients are no longer admitted the day before surgery. They arrive the morning of surgery. In fact, over 60% of surgeries are now done in the ambulatory setting. Technology has led to more complex procedures that are less invasive and therefore cause less morbidity during the recovery phase of surgery. Examples are minimally invasive surgery and robotic surgery. Advances in anesthesia complements advances in surgical technologies. So we have sophisticated monitoring devices, new pharmacological agents such as short-acting anesthetics, more effective antiemetics, improved postoperative pain management, and shortened procedure and recovery times. Incentives to reduce hospital stay and costs have resulted in pre-admission testing centers, known as PAT. Here, patient demographics, health history, consent forms, diagnostic, and laboratory tests are all completed. We also have ambulatory, same-day, or short-stay units. There are three phases of the surgical experience. Preoperative phase begins with the decision for surgical intervention and ends at the time of transfer to the operating room table. The intraoperative phase begins when the patient is transferred to the operating room table and ends when the patient is admitted to the post-anesthesia care unit known as the PACU. The postoperative phase begins with the admission of the patient to the PACU and ends after follow-up evaluation in the clinical setting or home. There are 5 classifications of surgery. Diagnostic is where the diagnosis is confirmed and established. Examples of how this is done are through a biopsy, exploratory laparotomy, or laparoscopy. Curative repair examples are excision, removal of tumor mass or inflamed appendix, and multiple wound repair. Reconstructive or cosmetic surgery examples are mammoplasty or a facelift. Palliative is performed to relieve pain or symptoms of a disease process. And rehabilitative surgery, an example would be a total joint replacement. How soon does a patient need surgery? Well, that is the urgency, and it is broken down into 5 categories. The first is emergent, and this is when the patient requires immediate attention. The disorder may be life-threatening, such as severe bleeding, bladder or intestinal obstruction, fractured skull, gunshot or stab wounds, and extensive burns. Urgent is when the patient requires prompt attention. The surgery is usually done within 24 to 30 hours, and examples would be closed fractures and infected wounds. With infected wounds, they'll do an incision, exploration, irrigation. One of the procedures is known as an IND, and that means incision and drainage of the wound. Required is when the patient needs to have the surgery. The plan is within a few weeks or months, and examples would be prostatic hyperplasia without bladder obstruction, thyroid disorders, cataracts. Elective is when the patient should have surgery. Failure to have surgery is not catastrophic, and some examples would be repair of scars, simple hernia repairs, and vaginal repairs. An optional surgery, the decision rests with the patient. It is a personal preference, and an example of this would be cosmetic surgery. Voluntary and written informed consent from the patient is necessary before non-emergent surgery can be performed. Who does it protect? First, the patient from unsanctioned surgery, and second, the surgeon from claims of unauthorized operation or battery. Before the consent is signed, the surgeon must provide the patient with the following. First, a clear and simple explanation of the surgery. Second, the benefits and alternatives to the surgery. Third, the possible risk, such as complications, disfigurement, disability, removal of body parts. And fourth, what to expect in the early and late postoperative periods. If the patient requests further information, the nurse notifies the physician. The patient is entitled to a second opinion. The patient may refuse the surgery. Never ever urge or coerce a patient to sign a consent. If the patient has questions, if they are hesitating to sign the consent, or if they're refusing the surgery, you need to document that in the EMR and relay the information to the surgeon so that arrangements can be made. Do not pre-medicate the patient prior to informed consent being signed. The consent is not valid if signed after the patient is pre-medicated. And the reason for this is that the pre-medication affects the patient's judgment and decision-making capacity. We need consent for invasive procedures. Some examples would be surgical incision, biopsy, cystoscopy, paracentesis, and the insertion of a central line. We need consent for procedures requiring sedation and/or anesthesia. Examples would be a colonoscopy or a bronchoscopy. Non-surgical procedures, some examples that require consent would be an arteriogram and scans with dye. Procedures involving radiation require consent, and blood product administration requires consent. How can we improve the consent process? First, we can provide audiovisual material to supplement the discussion with the patient. We can ensure the wording of the consent form is understandable to the patient. And signed consent should be placed in a prominent place on the patient's chart, and it accompanies the patient directly to the operating room. So who signs the informed consent? If the patient is of legal age and is mentally capable, they are the ones to sign the informed consent. A surrogate, who is usually a family member or legal guardian, may sign if the patient is neurologically incapacitated, cognitively impaired, or mentally ill. A healthcare proxy is for patients who are incapacitated. Actually, everyone should have a healthcare proxy, because when a patient can't speak for themselves, the healthcare proxy is the person who speaks for them. When there is no healthcare proxy and the patient is incapacitated, you must refer to the Family Healthcare Decisions Act for who will be the surrogate. And it's very specific, and it goes in order of first the legal guardian. If there's no legal guardian, it goes to a spouse or domestic partner. If none, then an adult child. If none, the parent. If none, the brother or sister, close friend, and last, the facility. An emancipated minor may sign their own consent, and this is someone who is married or independently earning his or her own living under the age of 18. What do you do in an emergency situation? Well, it may be necessary for the surgeon to operate as a life-saving measure without the patient's informed consent. In these cases, every effort is made to contact the family. During the preoperative interview, it is especially important to pay attention to not only the physical, but also the emotional assessment of the patient. We also want to ascertain previous anesthetics and the medical history. Baseline evaluation of the patient includes health history and physical exam. And under this, we want to include vital signs, be alert for signs of abuse. For allergies, note that allergies to kiwi, banana, avocado, or if the patient cannot blow up a balloon, this may be associated with a latex allergy. Family history, very important to include reactions to anesthesia from family members. Obstructive sleep apnea. If the patient is unsure because they're sleeping, so they don't know if they're having apnea while they're sleeping, you can use the stop bang assessment. And so you would ask a family member, does this patient snore? Or are they tired? Has anyone observed them having periods of not breathing while sleeping? Their blood pressure, their BMI, age, their neck size, and their gender. Diagnostic tests that we perform are blood test, x-rays, stool and urine test. Assessment, we assess all areas, including neurological, neurovascular, cardiac, pulmonary, abdominal, and skin. The goal in the preoperative period is for the patient to be as healthy as possible. We assess and address risk factors. We ensure necessary tests have been or will be performed. Appropriate consultations are done. We provide education about recovery from anesthesia and postoperative care. What we do is we prepare the patient for the anesthetic and the surgery, and every attempt is made to stabilize conditions that may hinder recovery. As part of the respiratory assessment, it is important to educate about the use of incentive spirometry and coughing and deep breathing to achieve optimum respiratory function prior to surgery. Include in the assessment underlying respiratory disease and smoking history. PAT is an optimum time to provide information about smoking cessation. Smokers are more likely to experience poor wound healing, SSIs or surgical site infections, VTEs, and pneumonia. For cardiovascular assessment, the older adult is at a high risk for cardiovascular complications because they usually have decreased or slower circulation to the rest of the body. The cardiovascular system exerts the most influence on anesthesia. Preoperative assessment needs to include blood tests, blood pressure, and EKG. These tests can identify potential risks such as anemia, hypertension, and arrhythmias. Hepatic and renal assessment. Preoperative optimization of liver and kidney function allows for medication, anesthesia agents, body waste, and toxins to be adequately metabolized and excreted from the body, both intra and postoperatively. For the endocrine assessment, dysfunction of the endocrine system such as thyroid disease, diabetes, adrenal insufficiency can have a negative impact on recovery. Patients on corticosteroids are at risk for adrenal insufficiency, and any steroid use up to 1 year prior to surgery should be assessed. The immune system, important part of this assessment is to determine the presence of infection or allergies. Some tests include CBC and urinalysis preoperatively. Delving further into assessment, first we really need to look at nutrition and fluid. Nutrient deficiencies can be a significant problem. Optimal nutrition is an essential factor for promoting healing and resisting infection. We look at obesity, poor nutrition, weight loss, malnutrition, deficiencies in specific nutrients. Nutritional deficiencies should be corrected before surgery to provide adequate protein for tissue repair. Dehydration and hypovolemia need to be corrected. Electrolyte imbalances need to be corrected. Previous medication use assessment. So when you are asking the patient about what medications they take, it's also important to include herbs and supplements. And if you look at Brunner, page 413, table 14.4, it lays out the herbs and supplements and how they can negatively affect surgical recovery. Dentition. Decayed teeth or dental prosthesis may become dislodged during intubation, and they can occlude the airway. Actually, any bodily infection, including the mouth, can be a source of post-op infection. Excessive alcohol consumption can cause arrhythmias, infection, withdrawal. Psychosocial research suggests pre-op fear and anxiety can lead to negative post-op outcomes. All of these can lead to significant problems with patients with comorbid medical conditions or the elderly. Special considerations. Let's talk about the gerontological patient first. Hazards of surgery for the aged are proportional to the number and severity of coexisting health problems and the nature and duration of the operative procedure. Older patients are a poor surgical risk, and it depends on other comorbidities. Their cardiac reserves are lower, their renal and hepatic function are depressed, gastrointestinal activity is likely decreased, dehydration, constipation, and malnutrition may be evident, and they have sensory limitations. They may have impaired vision and hearing. They may have reduced sensitivity to touch, so they could be more prone to accidents, injuries, burns. And a lot of older patients have arthritis. And this affects their mobility, not only preoperatively but intraoperatively in positioning the patient on the operating table. They can be difficult to turn, and they can have increased pain from the arthritis. Gerontological patients need a safe environment. They have decreased subcutaneous fat, so they are more susceptible to temperature changes, and they have decreased perspiration, so their skin can be dry, itchy, it can tear easily. Who requires more anesthesia, the young or the old? Well, the answer is that older patients require less due to decreased tissue elasticity in their lungs and cardiovascular systems. They have reduced lean tissue mass, and they have decreased plasma protein, which results in a more potent outcome from the anesthesia. Patients with disabilities, whether they're mental or physical disabilities, they need appropriate assistive devices. There needs to be modification of the preoperative education, additional assistance with and attention to positioning or transferring. And so an example would be a lip reader. If the patient is in the operating room and everybody is wearing masks, the patient can no longer read lips. So how do the OR staff communicate with this patient? And respiratory problems related to disabilities must be known to the anesthesiologist. Examples would be muscular dystrophy, multiple sclerosis. With obesity increasing, nurses are a part of a multidisciplinary team that will develop and implement clinical plans for patients who are obese. Obesity increases the risk and severity of complications associated with surgery. Patients who are obese have an increased cardiac demand. They are also at high risk for postoperative pulmonary complications. And the reason for this is that patients who are obese tend to have shallow respirations when supine, and this increases the risk of hypoventilation and postoperative pulmonary complications. They can have short neck syndrome, and they can have obstructive sleep apnea, which the patients, again, don't always know that they have. Fatty tissue is especially susceptible to infection. It increases the risk for dehiscence and wound infections, which we will discuss later. This is a list of medications that cause particular concern for surgery. For corticosteroids, they are not to be discontinued abruptly. If they are, they can cause cardiovascular collapse. So frequently, we administer steroids IV immediately before and after surgery. Diuretics may cause excessive respiratory depression during anesthesia, resulting from an associated electrolyte imbalance. Tranquilizers may cause anxiety, tension, and seizures if suddenly withdrawn. Anticoagulants increase the risk of hemorrhage during intraoperative and postoperative periods. Examples would be warfarin, heparin. MOA inhibitors, these are a class of antidepressants that may increase the action of anesthesia. The National Patient Safety Goals were developed by the Joint Commission and the Center for Medicare and Medicaid Services. The goal that we're going to discuss is to reduce surgical complications, and those are wrong site surgery, venous thromboembolism, surgical site infections, and timely administration of beta blocker medication. The nurse in the perioperative area needs to be alert for appropriate preoperative prescriptions aimed at preventing complications. Appropriate treatment begins before the start of surgery. And of note, particular beta blockers taken within 24 hours of surgery are associated with improved perioperative cardiovascular outcomes. This is from UCLA Health Surgical Quality and Patient Safety Group. It addresses the National Patient Safety Goal of reducing surgical complications. It addresses antibiotics, beta blockers, hair removal, indwelling catheter use, blood sugar control, and DVT prevention. And we'll discuss this a little more in length during lecture. Preoperative teaching is always taught on an individual basis. We need to use multiple teaching strategies. So we can use verbal, written, and return demonstration. When is preoperative teaching started? Well, it started early in the physician's office, in pre-admission testing, and we continue to the time the patient goes to the OR. Read your patient. Know if you are giving them too much information and making them more anxious, because if they're more anxious, they're not going to absorb what you are teaching them. Preoperative nursing interventions, we need to do an individual care plan, teaching, assess information, preparations, and the procedure needs to be explained. Delving further into preoperative teaching, under respiratory, we want to teach the patient how to deep breathe and cough, how to use the incentive spirometer, and there was a picture in the above slide for that. The importance also of not only how to do these exercises, but the frequency and the benefits that these will have for the patient in the postoperative period. How to splint their incision, whether it's with a pillow or just their hands. Mobility, position changes, how important they are and how to do them. Restrictions that may be specific to that patient's surgical procedure. How to exercise their extremities and the benefits of that. And again, in the previous slide, there was a picture of that. With ambulation, we want to remind the patient that the first time we're going to have a two-person assist due to their risk of orthostatic hypotension, and also because of they may have multiple tubes and lines that can get in the way. And TED stockings or pneumatic compression devices. For pain, the patient can have acute or chronic pain. They may have preoperative chronic pain, and postoperatively that chronic pain doesn't go away, but then you're adding acute pain to that. And then method and type of pain medication administration. And we'll talk later about those. Nursing interventions goal for nutrition and fluids. The food and fluid is withheld before surgery to prevent aspiration. Specific recommendations depend on the age of the patient and the type of food eaten. Studies show lengthy restriction of fluid and food is unnecessary in patients who do not have a compromised airway, coexisting disease, or disorders that affect gastric emptying or fluid volume. So examples of patients that may have these are pregnancy, obesity, diabetes, gastroesophageal reflux, enteral tube feedings, and ileus or bowel obstruction. Specific recommendations depend on the age of the patient and the type of food eaten. So adults may be advised to fast for 8 hours after eating fatty food and 6 hours after ingesting milk products. Most patients are allowed clear liquids up to 2 hours before an elective surgery. The goal for preparing the bowel allows for satisfactory visualization of the surgical site and to prevent trauma to the intestine or contamination of the peritoneum by feces. Ordered preoperatively for patients undergoing abdominal or pelvic surgery may be a cleansing enema or a laxative the night before surgery, which is then repeated in the morning. Antibiotics may be prescribed to reduce intestinal flora. The goal for preparing the skin. Preoperative skin preparation is done to decrease bacteria without injuring the skin. So at minimum, a preoperative bath with antimicrobial soap the night before surgery. In addition, cleansing with chlorhexidine wipes in the pre-op area under the direction of the RN. We never use razors, we use electric clippers. Hair removal usually is not necessary unless it interferes with the incision site. But if we do have to remove hair, it's removed immediately before the operation with clippers. In this slide, we see an example of a preoperative checklist. The preoperative checklist is usually started on the unit or in the pre-op area. Nursing interventions, immediate preoperative. The patient will arrive to the unit usually about 30 minutes prior to surgery. All information is reviewed, and safety in the preoperative period is a priority. The entire perioperative team participates in verifying the correct patient identity, surgical procedure, and surgical site before proceeding to the OR. The patient is identified by their bracelet on the patient, which could be not necessarily on a wrist, so it's important to communicate where that patient's bracelet is. We verbally ask the patient what procedure they are having and where. We compare consent with the OR schedule to make sure the correct procedure is listed. The patient will be asked the same questions about the procedure and the site again by the anesthesiologist, the MD who should mark the correct site, and then in the OR, a timeout period is done to confirm this information. We don't want to forget about the family. They're usually in the surgical waiting room. The surgeon will meet with the family after surgery. It is nice to give them at least an estimated length of surgery. We can't always be completely specific. Expected equipment after surgery, including IV lines, indwelling urinary catheter, NG tubes, oxygen, monitoring equipment. The surgeon's responsibility is to inform the family of the surgical findings and the prognosis. All articles of value, including assistive devices, dentures, glasses, and prosthetic devices, are given to family members or are labeled clearly with the patient's name and stored in a safe and secure place. Nursing diagnoses in this time are knowledge deficit, anxiety, altered family processes, body image disturbance, and risk for perioperative positioning injury. In this slide, you see classifications of medications that are frequently given preoperatively. The use of pre-anesthetic medication is minimal with ambulatory or outpatient surgery. The prescribed dosage of the medication is usually administered in the preoperative holding area. After the medication is given to the patient is kept in bed with the side rails up. And the reason for this is the patient can have lightheadedness and dizziness. Watch for untoward reactions to the medication, and that includes up to and including an anaphylactic reaction. The patient is transferred to the holding area 30 to 60 minutes before the anesthetic is to be given. They are transported by stretcher, and these rooms tend to be very cold, so make sure that the patient has enough blankets. What does on call to the OR mean? That means that a medication that is ordered on call, that is to be given once the patient is called for down to the OR. You do not want to give the medication prior to being called because often surgery is delayed or needs to be rescheduled. The surgical team is comprised of the anesthesiologist or CRNA, the surgeon, a circulating nurse, a scrub nurse, a surgical technician, and a registered nurse first assistant, which is also referred to as an RNFA. Anesthetists are qualified healthcare professionals who administer anesthetics. Most anesthetists are nurses who have graduated from an accredited nurse anesthesia program and have passed examinations sponsored by the American Association of Nurse Anesthetists, or CRNA. They meet the patient prior to the OR, could be in pre-admission testing or in the holding area. The type of anesthetic to be administered, previous reactions to anesthetics, and known anatomic abnormalities that would make airway management difficult are discussed. The patient is allowed time for questions. When the patient arrives to the OR, the patient's physical condition is reassessed immediately prior to initiating anesthesia. Anesthesia is administered, the airway is maintained, and then vital signs, EKG, blood gas levels, tidal volume, blood pH, and temperature are all monitored. The surgeon performs the surgical procedure and heads the surgical team. The RN first assist, the physician assistants, and the nurse practitioners. The scope of practice depends on each state's Nurse Practice Act. They work under the direct supervision of the surgeon. The first role in the nursing team that we are going to discuss is the circulating nurse. The circulating nurse is preferably an RN. 23 states in the U.S. have laws mandating this, and 16 additional states have similar laws governing ambulatory surgical centers. The circulating nurse manages the OR. They protect the patient's safety and health by 1, monitoring the activities of the surgical team, 2, checking the OR conditions, and 3, continually assessing the patient for signs of injury and implementing appropriate interventions. They lead the team's debriefing session following completion of surgery to identify potential areas of improvement and identify potential problems with post-surgical care. Second verification of the surgical procedure and site is the timeout occurs prior to the induction of anesthesia. Every member of the surgical team verifies the patient's name, procedure, and surgical site using objective documentation and data before beginning the surgery. Identifying patients correctly is a national patient safety goal. In this slide, we see 4 different patient positions on the operating room table. The captions call attention to safety and comfort features. All surgical patients wear caps to cover the hair completely. And you can also find this slide in your textbook, page 434, figure 15.6. The second role of the nursing team that we're going to discuss is the scrub nurse. The scrub nurse is responsible for the surgical hand scrub, the setting up of the sterile equipment, tables, and sterile field, preparing sutures, ligatures, and special equipment. They assist the surgeon and the surgical assistants. They scrub and circulate count all needles, sponges, and instruments, label all tissue specimens from surgery, and medication and implant labeling. So they do the labeling, who sends the specimens to the lab. That's the circulating nurse. This slide shows an example of an operating room. An operating room is stark in appearance, and the temperature is maintained anywhere between 20 to 24 degrees Celsius or 68 to 73 degrees Fahrenheit. So they're pretty cold. Sterile to sterile is sterile. Surgical asepsis prevents the contamination of surgical wounds. The sterile area must be kept in view at all times. Floors and equipment are cleaned frequently. If during surgery the sterile drape gets torn, it must be replaced immediately. Infection prevention is done through hand washing, sterile gowns, cap, mask, and sterile drapes. For some procedures, they also need to wear goggles, rubber boots, and waterproof aprons. When they double glove, they must be aware of latex allergies. Another national patient safety goal is fire prevention assessment in the operating room. And the reason fire is prevalent in the operating room is because there is a source of fuel, an oxygen source, and a mechanism to ignite fire, which puts the operating rooms at risk. This is an example of a surgical safety checklist. You can also see it in your textbook, page 419, figure 15.1. A surgical safety checklist was adopted worldwide to reduce medical errors, increase patient safety, and improve interprofessional communication. There are 5 types of anesthesia. The first is general anesthesia, which we will be discussing in a little more detail here. Inhalation and IV is how it's administered. Regional anesthesia is given through an epidural, spinal, or local conduction blocks. Then there is the third one is moderate sedation. The fourth is monitored anesthesia care, or MAC. And the fifth is local anesthesia. In general anesthesia, the patient is not arousable and the client is on a ventilator. For lecture, I'd like you to think about some of the advantages and disadvantages for us to discuss about general anesthesia. General anesthesia is a state of narcosis or severe central nervous system depression produced by pharmacological agents, analgesia, relaxation, and reflex loss. There are 4 stages. Beginning anesthesia occurs when the inhaling agents are given. The patient may have ringing, roaring, buzzing in their ears, though they may still be conscious. They have an inability to move their extremities easily, and noises are exaggerated. So while anesthesia is beginning, we want to avoid all unnecessary noises in the OR. Excitement, the second stage, may have uncontrolled movements, and someone should be ready to apply straps to restrain the patient. It is characterized by rapid pulse, irregular respirations. We want to keep the patient safe, And in case of vomiting, we apply cricoid pressure. The third stage is surgical anesthesia. Patient is quiet and lays on the table. They are unconscious. The patient will go from light 1 to deep 4 depending on the anesthesia administered. Respirations are regular, the pulse is regular, the skin is pink and flushed. The last stage is the stage we want to avoid, and that's called medullary depression. If too much anesthesia is given, respirations become shallow, the pulse is weak, the pupils become dilated and can no longer constrict. Cyanosis develops, and without intervention, death rapidly follows. The anesthetic must be discontinued immediately. Respiratory and cardiac support to prevent death must be put into place. Narcotic antagonists must be administered if the overdose is due to opioids. There should be no delineation between stages 1 through stage 3. Stage 4 should not occur if the anesthetic is given smoothly. This is up to the anesthesiologist to perform appropriately and to always be assessing the patient. In regional anesthesia, the client is awake and alert. An anesthetic agent is injected around nerves so that the region supplied by these nerves is anesthetized. Epidural is the preferred route. The advantage is no headache. Local anesthetic is delivered into the epidural space. It blocks sensory, motor, and autonomic functions. Spinal anesthesia, the anesthetic is injected into the lumbar space, usually between L4 and L5. It produces anesthesia of the lower extremities and lower abdomen with resultant paralysis of the toes, perineum, then legs and abdomen. A peripheral nerve block is used in conjunction with general or MAC anesthesia. It targets a bundle of nerves. And in these pictures, you can also find these in your textbook, page 428, figure 1515. But in injection sites in A for spinal and epidural anesthesia. In B, it's a cross-section of an injection sites for peripheral nerve, epidural, and spinal blocks. Moderate sedation, also known as conscious sedation, involves the use of sedation to depress the level of consciousness without altering the patient's ability to maintain a patent airway and to respond to physical stimuli and verbal commands. And it's used in procedures, short-term procedures such as gastroscopy, endoscopy, elective defibrillation. Monitored anesthesia care, or MAC, is moderate sedation that is given by an anesthesiologist or CRNA who is prepared to convert to general anesthesia if necessary. There are several intraoperative complications to be aware of. The first, anesthesia awareness. The patient is cognizant of the surgical interventions while under general anesthesia, meaning they can't move, they can't speak, but they are actually aware of what is going on. Nausea and vomiting. To treat that, we turn the patient on their side, suction their mouth for secretions and vomitus, provide a patent airway, and the anesthetist may administer antiemetics. Anaphylaxis is a life-threatening. It causes hypotension, vasodilation, and bronchial constriction. The important thing is that the airway is maintained. Be aware of latex allergy, and if the wound has to be closed quickly, certain sealants can be used on the surgical sites. Respiratory complications. Respiratory depression by the anesthesia, spasms of the vocal cords, relaxation of the tongue, aspiration of vomitus, which can lead to hypoxia, which can lead to brain damage. Hypothermia. Anesthesia causes the temperature of the body to fall. Glucose metabolism is reduced. Metabolic acidosis may develop. The core body temperature is less than 36.0 degrees Celsius or 96.8 degrees Fahrenheit, and it's caused by low temperature in the OR, infusion of cold fluids, inhalation of cold gases. We treat with warm blankets, forced air warming. We can increase the OR temperature to 78 to 80 degrees, warmed IV fluids, and all wet linens or gowns are removed as quickly as possible. When rewarming the patient, it is done gradually. Unintended hypothermia is associated with adverse outcomes such as bleeding, delayed wound healing, increased length of stay in the PACU, cardiac dysfunction, and increased inpatient hospital stay. Malignant hypothermia. This is an inherited muscle disorder chemically induced by anesthesia. The pathophysiology is related to muscle cell activity. Disruption of the calcium pumping action into the cells. Calcium ions are not returned and they accumulate, causing hypermetabolism, which in turn increase muscle contraction or rigidity and damages the nervous system. DIC, disseminated intravascular coagulation, is a coagulopathy, thrombus formation and depletion of coag proteins, and it can lead to organ damage. The first question is multiple choice. Which medication classification must be assessed during the preoperative period because it can cause an electrolyte imbalance during surgery? A, corticosteroids, B, diuretics, C, phenothiazines, D, insulin. Come prepared to lecture to answer that question. The next 4 questions are true or false. The most frequent early sign for a patient at risk from malignant hypothermia subsequent to general anesthesia is bradycardia. Question number 2. It is the nurse's responsibility to provide appropriate information concerning surgery and obtain the written consent. 3. Safety is one of the most critical concerns during the intraoperative period. 4. Medullary depression, the 4th stage of anesthesia, is necessary and a vital stage during complicated surgeries. Come prepared to lecture to answer whether these are true or false. And this ends the slide presentation.